Hello everyone, this is Dr. Seher from dentabest.com, your best mentor. I'm here to provide you the best guidance and smart study tips for preparing all the subjects for your clinical and the basic sciences. And that will help you a lot with the INBD, ADAT, AFK as well as Part 2 examination. So first subject that we are going to discuss today is endodontics. We have a good comprehensive review about the high yield facts, the must read areas, and what are the important questions that can be asked from this slide. So the topics we are covering here is the pulp, periradicular disease, vitality testing, cracked tooth, perioendo, purpose of obturation, and purple periapical diagnosis chart. And the surgical endo, we are covering endo emergencies, procedural complications, examination of teeth with trauma, treatment in dental office, tooth resorption, adjunctive endotherapy, the causes of endo failure, and the rotary instruments. Okay, so let us come to the next slide where we discuss about the types of dentines. So we know we have three dentines, primary, secondary, and tertiary. Primary is formed before the root closure, secondary after the root closure, or tertiary reparative dentine is formed in response to trauma, attrition, cavity preparation. It's also called the reactionary dentine. Now, pulp. One thing that is important here that any sensation you give to the pulp, any stimulus, whether it is hot, cold temperature, pressure, blast of air, touch, everything is perceived in the pulp only as pain because pulp only has fibers for pain. The A delta for the sharp pain and the C fibers for the dull pain. So A delta sharp pain that you perceive in reversible pulpitis, where the pain is quick, sharp, momentary, it comes with the stimulus, and as soon as you remove the stimulus, the pain is gone. But the C fiber pain is more dull, throbbing pain that you can see with the advanced stages of pulpitis. Always remember C fibers, they have a higher threshold as compared to A delta fibers. So C fibers are not easily excited. They're excited by hot liquids and relieved by the cold. Normal pulpal response will be asymptomatic, but with the stimulus, you are going to have the mild moderate response. But percussion or palpation, it doesn't cause any response in the normal pulp. Since the pulpitis, which starts, so first stage in pulpal inflammation is pulpal hyperemia. That is going to progress to reversible pulpitis if not controlled, and finally leading to irreversible pulpitis. Irreversible pulpitis, the signs of necrosis have already started, and finally the pulp will be completely dead. But irreversible pulpitis and partial stages of pulpal necrosis can mimic the symptoms with each other, with the pain increased by the hot and relieved by the cold. Reversible pulpitis, since it is reversible, the pulp has a chances to come back to normal again. For example, doing the amalgam restoration without a base. Patient is coming back the next day with hot and cold. So what you do, you remove the amalgam restoration, put a permanent base, and the pulp is going to become normal again. Irreversible, we have the symptomatic where the pain can come on its own, so spontaneous pain, unprovoked pain, and with the stimulus, the pain that you're feeling is going to be lingering, that stays for more than 10 seconds even after the stimulus is removed. Also in the symptomatic irreversible pulpitis, you can have pain on postural changes. For example, when you're sitting, you don't have pain. When you lie down, you're going to have the pain. While asymptomatic, like your internal resorption or hyperplastic pulpitis, it doesn't come with the symptoms. Okay, so let's see the next slide here of sign of periradicular diseases. So as compared to pulpal condition, periradicular conditions, patient will have more complaint to chewing, biting, swelling, fever, feeling pain, and loss of lamina dura apically. Pulpal conditions, the pain in pulpitis is more diffuse pain, the pain which is referred as well. But periradicular condition, the pain is more localized, where actually patient can pinpoint that this is hurting, because PDL has proprioception, which is not present in the pulp. So we can see different conditions here like AAP, which can be seen with a vital or a non-vital tooth, sensitive to percussion. Vital tooth with occlusal trauma can develop this. Non-vital tooth due to over-instrumentation or overfilling can develop that. That leads to inflammation of PDL in the periradicular region. Now, the acute periapical abscess in which the tooth is dead, number one, painful purulent exudate that is seen around the apex, swelling, pain on percussion and palpation, and how you differentiate it from LPA or lateral periodontal abscess, as the tooth is still vital there and there is a periodontal pocket as compared to acute apical abscess where the tooth is very non-vital. Now, in the CAP or chronic apical periodontitis, it becomes a long-standing asymptomatic condition, which is tooth is dead here, an important feature of periapical radiolucency. Now, in this asymptomatic condition, the patient suddenly start having the pain, that is acute exacerbation of CAP, that is called as the phoenix abscess, which has all the feature of CAP except that it is a painful condition. Now we can see the suppurative periradicular periodontitis, where we have the chronic periapical abscess that can lead to that with a draining sinus tract, all the pus is being drained out, so it becomes asymptomatic. Tooth is very non-vital here. There is a periapical radiolucency, treatment is RCT, and once after doing RCT, the sinus tract are going to get resolved. The last condition here is chronic focus coralizing osteomyelitis. In this, you have excessive bone mineralization around apex of the asymptomatic vital tooth, and it's a low-grade pulpal irritation. So since the tooth is very vital, it's a benign condition, so it doesn't require any endodontic therapy. Now you can see different types of vitality testing: percussion, palpation, thermal testing. So the most accurate method is giving cold water bath to the tooth after doing rubber dam isolation. And most commonly used method, we know it's endo ice. While the heat testing, warm gutta percha filling considered to be the most commonly used method, but most accurate is hot water bath to the tooth with a rubber dam. Now, if the thermal testing is not working good, then you can go for EPT. EPT, although, is just a supplementary or adjunct to thermal testing, because it's thermal testing that gives you a real indicator of vitality, because this is the one that is going to tell you how is the blood supply to the pulp, but EPT is going to tell you just the nerve function. Also with EPT, we have a problem of a long list of false positive and the false negative that you can clearly see. So false negative is when the tooth is vital, but the test is saying tooth is non-vital. So the most common case is a recent trauma when the nerves are just temporary paresthized and they are giving you a false negative, although the tooth is not dead. That's the reason in a RCT, in a dead tooth, you don't jump and do RCT, right? You repeat your vitality testing in 6 weeks, 2 months, 6 months, yearly intervals. And every time the tooth is coming non-vital plus a periapical radiolucency has developed or the patient has become symptomatic, then only you are going to do the RCT. False positive means the tooth is not vital, but the test is saying tooth is vital. For example, in the case of necrosis, liquefactive necrosis, patient can still become symptomatic here. And anxious patient, they feel pain all the time, so they can still feel the pain in the tooth which is dead. Let's see, this is the cracked tooth syndrome we have. And in the cracked tooth syndrome, most important feature is that patient is going to come to your office though with a pain on biting, but actually the pain is not on biting. Pain is actually when he releases the bite. That's when actually he feels the pain. It's not easy to see on the radiograph, the cracked tooth. So the most accurate method is actually transillumination. However, the most commonly used method is wedging the tooth and taking the x-ray or using a tooth sleuth. You can have a cracked tooth with the healthy pulp, reversible pulpitis, painting with the orthoband, that's a treatment. While irreversible pulpitis or necrosis, cracked tooth, you can do the RCT, restoration, and finally crown it. When the fracture goes through the entire mesiodistal surface, it is going to have a poor prognosis. Now, when we talk about the vertical root fracture, so the vertical root fracture, one thing that is important here is we can see the clinical features. So the tooth with the vertical root fracture is mostly the tooth which is endodontically treated tooth. If you put too much of pressure while condensation, that is common reason of vertical root fracture, mostly seen in the lower molars area. And this tooth has hopeless prognosis. So there is nothing you can do with that root. You just have to remove that tooth. If it's a single rooted, it's a multi-rooted, you can remove the tooth with the root fracture. You can see in the picture, you can see this is a J-shaped radiolucency that can be seen on the radiograph. But it's difficult to see, you have to change many angulations. However, exploratory surgery, raising a flap to clinically directly visualize the fracture in the root is considered to be the most accurate method. Now we can see they are different here: hemisection, bicuspidization, root resection. So hemisection is you are surgically cutting the tooth into two halves, usually the mandibular molar, and you are removing the disease half. While in bicuspidization, you are retaining both the halves, but you're turning them into two premolars, a molar into two premolars. So why you're doing that? To gain more accessibility, more visibility in the furcation area, to treat the resorption or to treat the furcation involvement. But whatever halves you are retaining, or the two halves you are retaining, like in bicuspidization, or half you are retaining in hemisection, the remaining half should be done RCT on, and you have to shape it like a premolar and properly crown it. Root resection, you are just removing the root, like in a multi-rooted tooth. The intentional reimplantation, you are intentionally removing the tooth on purpose, extracting it out to do the apicectomy or root end procedure outside the tooth, and then you put it back. So this is one of the last resorts. When nothing works, then you go for intentional reimplantation. Surgical RCT, non-surgical RCT, nothing is working. Because the most important thing when you do intentional reimplantation, you have to be sure that when you are reimplanting the tooth, it has to regain its attachment, it should have a good periostatus, and you should be able to skillfully remove it without fracturing the tooth. Root submersion, you are resecting the root 3 mm below the alveolar crest. This is mainly done to prevent the root resorption in the. Now cone image shifting, that's related to your slob root, that is same of lingual, opposite of buccal. So when you are shifting the X-ray cone towards one side, let's say mesially, the canal also appear to shift mesially. That means shifting on the same side, that is lingual. If you shift your X-ray cone mesially and the canal appear to shift distally, that means shifting on the opposite side, that means it is present buccal. So you can see mainly for identifying the superimposed buccolingual directions you can determine by using your slop technique. Now radiolucent endodontic lesion, always remember whenever you have endo condition, tooth always turns non-vital. Apical lamina dura is absent. And radio-opaque condition, tooth can be still vital, there can be radio opacity with the diffuse water. Now how you are going to distinguish the radiolucency at the mandibular second premolar is your mental foramen and not periapical pathology. You change the angulation, pathology is going to stay there, but mental foramen will shift. Also based on the size, definitely foramens are very minute, less than 0.5 mm, and pathologies are usually larger than that. Also with the borders, so mental foramens, they don't have clear border, they are very light shadows, while the pathologies will be very well defined, sharp, circumscribed borders. You can see some of the procedural complications here, like the ledge, artificial irregularity that has been created. Achieved instrumentation and obturation will be short of apex. And lack of straight line axis is the most common reason of ledge to be formed. So you have to relocate the canal, renegotiate it, and re-establish the working length with the plenty of lubricants. Also, you can use reaming motions. Let's say if you cannot remove the ledge, you can just fill it up to the ledge level. You can see in this slide, the instrument or file is breaking inside. Most common reason when you're a beginner, you don't know how much stress to put on the instrument, you are breaking up the file. So use lots of lubrication, know how much stress to put on the file, replace your files more often, discard them, it's time to replace them. And you can do the bypassing, just like you bypass the ledge or overextended guttapercha, or remove the instrument. Most likely if the instrument has gone beyond the apex, there is nothing you can do, you have to refer to endodontic surgeon who is going to raise the flap and remove the broken instrument. If the instrument has gone beyond the apex, that's what I told you, you have to raise a flap. Now let's say if the instrument has broken in apical 1/3, you can just treat that broken instrument as the apical stop for you, and you can just fill the canal to that level. Now you can see the perforation. So there can be different type of perforation that you created, so operator induced iatrogenic communication, and corneal perforation, furcal, strip perforation, root perforation are different types. And you can see on the X-ray, your file will deviate from its original path. When it is perforated, there can be sudden pain. So it all depends, prognosis or outcome of case depends upon what level is the perforation. Above the crustal bone, it has favorable prognosis. Below the crustal bone, it has a poor prognosis. Definitely the perforations which are smaller than size, sooner the so you can see here, we have also given here that how you manage. So the most important or most beneficial storage media we have is Hank's Balance Salt solution, or at home, patient can just store the tooth into milk. So once your tooth has been managed, like you're holding the tooth from its crown, not by its root, and you're reimplanting the tooth, slowly you're splinting it for 7 to 10 days, but it has to be physiologic splint because you don't want the ankylosis to happen. Remove the debris from the socket and immerse the tooth in 2.4% sodium fluoride solution for a closed apex tooth stored in a media. But if it is out of the socket time is more than 1 hour, because chances of necrosis are there. So in that case, you have to put the tooth in sodium fluoride solution for it to remineralize. We can refer to the guidelines. And once your splinting time is over, then you can do the RCT. Usually the open apex tooth, they are not reimplanted if their external dry time is over 60 minutes. But less than 60 minutes, open apex tooth, you can put them in doxycycline solution, remove the coagulum from the socket with the saline gentle irrigation, just you do for other socket. You don't curatize the socket, and then you do the same splinting. Systemic antibiotics and tetanus boosters might be needed. Now we can see here the external surface replacement resorption, and there are different types of external resorptions we have. Surface, which is the mildest kind, and this is the ankylosis when the tooth is directly fused with the dentine. There is no cementum, no PDL. We can see the tooth has metallic sound and percussion. It is a submerged tooth. While in cervical resorption, you can see here the tooth will look like pink color, just like your internal resorption has a pink tooth. How you distinguish? You change the angulation. You will see cervical resorption is external on the CJ, while internal resorption is internal. The most common cause of cervical resorption has an adverse effect of bleaching of the non-vital tooth. Then you have inflammatory root resorption when the root is still necrotic from trauma. Apical and lateral abscess and internal resorption, we already discussed about it. It's a very important condition. Now, pulpotomy is done on a vital primary tooth. So let's say you have a deep caries in the vital primary tooth, you can do the pulpotomy. So what you are going to do, you are going to remove only the pulp from the coronal pulp chamber, not touching the root because tooth is still vital. And then you can do a formocresol pulpotomy or a ferric sulfate pulpotomy. Why not calcium hydroxide here? Because for primary tooth, both calcium hydroxide and MTA, they can lead to internal resorption. Now, apexogenesis and apexification are the other two procedures. Apexogenesis is done on a vital, immature permanent tooth, where you are going to do the pulpotomy first, and then you are going to put the calcium hydroxide on the pulp stump. So you are preventing the tooth from getting non-vital. At the same time, you're giving the time to the tooth to close its apex. While apexification is another procedure in which the tooth has turned non-vital. When the tooth turns non-vital, then you are going to do the pulpectomy first, remove the entire pulp from the root and the crown and the coronal pulp chamber, and then you are filling the canal with the calcium hydroxide methyl cellulose paste. So in case of apexification, you are inducing the root closure. You are creating an artificial barrier. So when you use calcium hydroxide, you can definitely do the, in 3 months, it will create a barrier and then you can fill up the canal. While use MTA, you can do the obturation the next day itself. Okay, so the next slide we have, it is on apexification and pulpotomy. So as we discussed on the last slide, that apexogenesis was for immature vital tooth, while apexification is on immature non-vital tooth. So for doing apexification, firstly you have to do pulpectomy, that is removing the entire pulp from the crown and the root canal, and then you're going to fill the canal with the calcium hydroxide paste, and you can create an artificial barrier within 3 to 6 months by using calcium hydroxide, so you can fill up the canal later. But using MTA, That's your mineral trioxide aggregate. That's a very good, very biocompatible cement. You can expect the barrier to form the next day itself within 24 hours. Now, when you do the bleaching of a non-vital tooth which has been discolored due to chemicals released from RCT, the most important step is to place a cement barrier like a zoe or a cavit so that the bleaching chemical is not penetrating through the dentinal tubule and not creating this cervical resorption, which is the most common adverse effect of bleaching of a non-vital tooth, where you're placing a rubber dam, removing the corneal portion of gutta percha, and then you're putting the bleaching agent on the facial surface, and every 3 to 4 days you're monitoring for the color change. Now, post-treatment, definitely corneal leakage is one of the very big problem. If you're not sealing the canal properly, the infection contaminants can still flow back into the canal and lead to failure of your RCT. That's the reason single sitting RCT are so successful when you are sealing the canal with a permanent restoration the same day you are filling up the canal. Now, there are different causes of endo failure, as we know, but the most important cause is inadequate debridement when you're not cleaning the canal properly. That's the number one cause. Number two cause, definitely not sealing it properly, not doing proper obturation. However, missing the canals, like canals in case of accessory canal, or missing the MB1 canal of the maxillary first molar, vertical fracture, perio involvement, procedural errors, resorption, and also compromised host factors are the important cause, or you should say common cause of endo failure. Now, how many canals are present in the maxillary and the mandible? It's a simple memorization that you can go through it. Rotary instruments. So you can see in the hand instruments, we have the broaches, barbs, file. Broaches are used in the beginning to remove your extirpation of your pulpal tissue in the starting once you have made the access cavity and located the canal, but they're not for cleaning or enlarging the canal. They are very thin, they can easily break. Then you have the reamers. Reamers are different from the files in a way that reamers have more flutes as compared to files, and reamers can only be used for clockwise, counterclockwise action, while files can be used both in the filing action and the reaming action. Then you have the H file, which are called as Christmas tree file, with the intersecting cones we have. Hi, my dear student who are preparing for IMD ADAT Part 2 exam. Thanks so much for watching this review video of the subject. If you really liked it, please buy the full version by clicking on the link given in the description. With the purchase of every video, you will be getting free live assessment and evaluations on the subject as well. Also, don't forget to subscribe to the Dentabest channel now to get the latest updates on the smart videos. If you have any questions, please comment me in the box below. I, Dr. Seher from Dentabest, wishes you all the best for exam, and thanks again for watching.